Mcpap, and we are very happy to welcome you to our Mcpap Clinical Conversation session, which, as you know, always takes, well, not always because there are exceptions, but it takes place generally at the fourth Tuesday of every month. The topic for today is our training and an introduction on our brand new Pediatric Autism Spectrum Disorder Clinical Practice Guideline. Before we start, just a few housekeeping points. I guess the first is that the session will be recorded and available on the Mcpap website at www.mcpap.com. And so feel free to tell your colleagues about it, and they can always just go to the website to listen to it and watch it. And the slides actually are also available on the website as well, under the Toolkits and Resources page under PowerPoint presentations. We are happy to address questions throughout the presentation. So if you have a question, just type it into the question box in the interface or into the chat, and we will monitor the chat and we'll read your question. If you would prefer to ask yourself, then you can indicate that, and we would be glad to prompt you when it's time to ask it, and we can unmute your line at the time. At the very end, we would be very appreciative if you would fill out a brief survey that will pop up. And we really appreciate and really need your feedback so that we can make sure that future presentations are tailored to your needs. All right, so I'm going to go ahead and introduce our speaker. So our speaker is Dr. Carrie Vaudreuil, and she is a child and adolescent psychiatrist. She did her medical training, or medical education at Duke University Medical School, and she did her general adult psychiatry residency training at the Harvard Longwood Psychiatric Residency Training Program. And then she went on to do her child and adolescent psychiatry fellowship training at Mass General McLean Hospital, which is a combined fellowship program. In addition to her work with Mcpap, Dr. Vaudreuil works as a adult and child psychiatrist at Mass General, and she works in the pediatric psychopharmacology program within MGH. Dr. Vaudreuil is also a researcher, a clinical researcher, and her research interests are focused on emotional regulation, and she's received several research awards, including the DuPont, Warren, and Livingston Fellowships awarded by Harvard University. She received a Pilot Research Award for Child and Adolescent Psychiatry Residents and Junior Faculty from ACAP, which is the American Academy of Child and Adolescent Psychiatry. And she also received a Louis V. Gerstner III Research Award. So join me in welcoming Dr. Vaudreuil, and I'll hand it right over to you, Carrie.
Great, thanks. Thank you so much. So I am here to talk today about the management of psychiatric symptoms in children and adolescents with autism spectrum disorders. As an overview of what we're going to be discussing today, first I'm going to briefly touch upon how to access the Mcpap guidelines and show you our new Mcpap guidelines focused on the treatment of autism spectrum disorders. We're going to go through the diagnostic criteria of autism spectrum disorders. I'm going to present some facts about the epidemiology of autism. We will talk briefly about various important points in terms of the clinical assessment of autism, talk about how to distinguish autism from other psychiatric disorders, briefly touch upon services that are important for children with autism spectrum disorders, and then we'll get into the medication management and monitoring that can be involved in managing various psychiatric symptoms of children with autism. And then at the end, we will have time for questions and comments. So before I start talking about autism spectrum disorders, I wanted to make sure that everyone here today knows how to find our clinical guidelines, which we publish on our website. And this is meant for all pediatricians and primary care providers, or really anyone who's looking for more information about how to diagnose and treat psychiatric disorders in children. So if you go to our website, which is at www.mcpap.com, we have a For Providers tab. And if you click on that tab, you can see all the resources that we have available, but specifically I want to draw your attention to the diagnostic resources section. If you click on diagnostic resources, it will bring you to a page that looks like this. And you can see on the left of the screen, it lists a number of psychiatric disorders that we have published guidelines and clinical pearls on. And what we do is we have a leadership team, which consists of site directors from all of our Mcpap sites, and we meet together on a monthly basis and talk about how to provide information to primary care providers in a brief published format that they can access online if they need some guidance or assistance in treating psychiatric disorders in children. If you click on one of these disorders, it will bring you to a page where you can see the guidelines that we've created, clinical pearls about the disorder, and then sometimes there are PowerPoint presentations or other presentations that our staff has created that you can also access on our website. So the autism guidelines, we just completed them. They haven't been put up on the website yet, but they should be there shortly. But I just wanted to give you a brief look at what they look like. So it's created in a Word document in sort of a flow sheet manner to help walk you through the different steps you might take when evaluating autism spectrum disorders and the different points you might consider when thinking about assessment and treatment. So we're going to go through all the information provided in the guidelines as part of this talk, so I don't necessarily want to spend a lot of time on that at this moment, but that's what the guidelines look like if you want to refer to them on our website later this week once they're published. So the first thing I want to go over today is just the diagnostic criteria of autism spectrum disorders. As many of you are aware, I'm sure, screening for autism spectrum disorders is common, routine part of pediatric practice in younger children. And autism can be reliably diagnosed by age 2 in a lot of children. However, the majority of autism diagnosis actually occurs after age 4, which means a lot of our kids with autism spectrum disorders are not being picked up with that general screening that's employed in pediatric practices. And so it's important to familiarize yourself with the diagnostic criteria for autism spectrum disorders, because if you have a child who is older and is presenting with some of these symptoms, it might be worth sort of reconsidering an autism diagnosis, even if this child wasn't necessarily flagged as potentially having autism when they were younger. So there are two main criteria in diagnosing autism spectrum disorder. Criterion A is persistent deficits in social communication and social interaction across multiple settings or contexts. And for Criterion A, there are 3 symptoms, and patients have to exhibit deficits or problems in all 3 symptom areas of Criterion A in order to meet criteria for an autism spectrum disorder. The next major criterion is Criterion B, restricted repetitive patterns of behavior, interest, or activities. There are 4 different symptom categories listed for Criterion B, and someone has to have 2 of those 4, meet criteria of 2 of those 4 symptom categories in Criterion B, as well as I previously said, all 3 of the symptom criteria under category A. And I'm just going to go into this in a little bit more depth because this can be sort of wordy and jargony. And so I want to explain a little bit what some of these categories mean. So Criterion A, again, is deficits in social communication or social interaction. And point 1 is deficits in social emotional reciprocity. So Before I start giving examples, I just want to say that, first of all, some of these examples are going to be behaviors that are normal in children at certain ages, right? So some of these behaviors are developmentally normal at young ages, and then at later ages, they become not consistent with development anymore. And so if a child has some of these behaviors, you want to take into account, is this something that would be developmentally normal at the age that the child is at? Because sometimes something that's normal for a 2-year-old is not normal for a 7-year-old. And so just because a child has some of these behaviors doesn't necessarily mean that they have an autism spectrum disorder. And likewise, when we're thinking about diagnosing autism spectrum disorders, we're looking at the whole picture. So do they have sort of multiple examples of meeting these symptom criteria in all of the required categories in order to get the diagnosis? And that's also important because, again, some of these behaviors, kids are going to exhibit these behaviors. And just because they have 1 or 2 of these symptoms or exhibit a few of these behaviors does not mean that they have an autism spectrum diagnosis. So as I'm going through this, I want you to sort of keep that in your mind, that these are examples of behaviors that children may exhibit, but again, these behaviors can be seen in neurotypical children as well. So the first symptom category in this category is deficits in social emotional reciprocity. So an example of that might be difficulty having a back and forth conversation. So for example, a child with an autism spectrum disorder may talk on and on and on about a topic of interest without pausing to let the person they're talking to interject. They may not look for any feedback from the person they're talking to about whether that person is interested or has something that they want to say. Or conversely, someone with an autism spectrum disorder may fall on the other end of the spectrum and may not be able to make small talk, may just frankly not know how, or may not be interested. So this may be a child who you say, "How are you today?" And they say, "Fine," and then look away. And there's, no reciprocity. They're not asking you how you are and waiting for a response as would be sort of considered within the social norms. And again, as I'm saying this, it's making me think there are plenty of teenagers out there in the world who will have that response to their parent. And again, it doesn't mean that they have an autism spectrum disorder. This is just sort of an example. But if this is a pervasive behavior across multiple settings where they act this way with peers and parents and teachers and coaches, it may be something that you want to sort of think about. Is there something else here? If it's just a teenager who doesn't want to talk to their mom today, that's sort of a different situation. Also within this category is reduced sharing of interests, emotions, or affect. So what does that mean? Someone with an autism spectrum disorder may not get excited when something exciting happens to someone else in their family. They may not respond appropriately if someone's sad or injured. So if a friend falls and gets hurt, they may not go over and try to comfort them. They themselves may not seek out comfort appropriately. If they fall and get hurt, they may not look for a parent to comfort them. They may not want to go out of their way to engage other people if something exciting happens to them. So those are examples of things that may fall within this category. Symptom criteria number 2, deficits in nonverbal communicative behaviors used for social interaction. So the most common one we think of are limited use of eye contact. So you often hear about children with autism spectrum disorder having limited eye contact, but this really encompasses a lot more than that as well. So for example, this includes lack of gestures, lack of facial expressions, lack of tone of voice. A child with autism spectrum disorder may not have normal intonations of voice. They may talk on and on in a very monotone manner, for example. And similarly, they may not use nonverbal cues. They may also not understand nonverbal cues. So they may not be able to recognize when someone's getting angry or when someone's bored or when someone's sad. And it's not that they don't care, it's that they're really actually not picking up on those cues. They may also have difficulty understanding humor or sarcasm. They may not get jokes, things like that. And symptom criteria 3, deficits in developing, maintaining, and understanding relationships. People often think of children with autism disorder as having a lack of interest in peers or having a lack of interest in socialization. And that can certainly be something that we see in people who have autism spectrum disorders. There are certainly people out there who have autism who are not interested in social interaction. But I actually find that a lot of people with autism spectrum disorder are very socially interested and socially motivated, but they just don't necessarily have the social skills to engage appropriately in social situations. And so sometimes that means that they're interested in peers, but they have difficulty making friends. And sometimes it can mean that they are interested in social interaction, but they know that they struggle, and therefore social interactions can make them very anxious. But examples that would fall under this symptom criteria include difficulties adjusting behaviors to different social contexts. So these kids may not understand that that people act differently when you're with a friend versus when you're with your parents versus when you're with your teacher. So you may have a kid who acts inappropriately familiar in a more formal setting with an older adult. You know, they're acting as if that person is their friend and maybe it's someone they've never met before. Or they may be overly formal in casual situations. You hear a lot about lack of imaginative play in autism spectrum disorder, you know, not having pretend friends or playing pretend games. And then, as I mentioned before, children with autism can be socially motivated, but have difficulty making friends. But again, I want to reiterate that just because a child is socially motivated or interested in peers does not mean that they don't have an autism spectrum disorder. Criterion B, restrictive, repetitive patterns of behavior, interests, or activities. Again, there are 4 symptom criteria that fall in this category, and someone has to meet criteria for 2 of the 4 symptoms. So number 1 is stereotyped or repetitive motor movements, use of objects or speech. So that could include repetitive body movements, rocking, flapping, spinning, repetitive motions with objects, or ritualistic behaviors. So for example, these are kids who, instead of racing their cars, they may spin the wheels over and over again or line them up, but not actually play with them in the way that they're sort of meant to be played with. Echolalia is repeating words, sounds, or phrases over and over again, and may include even repeating the intonation of the way something was said. So for example, kids may see something on TV, or they may hear something that a parent or teacher said, and they may repeat those words or phrases over and over and over and over again, using that same intonation that they heard that phrase said with in the first place. And then idiosyncratic phrases means speaking in a way that everyone assumes that you know what they know. So a common example of this, again, not necessarily related to autism spectrum disorder, but something I think anyone who works with kids can understand, is when that child comes into your office and starts talking to you about a video game or a TV show that you've never seen and you have no idea what they're talking about. So that would be an example of idiosyncratic speech. But a more clear example, specifically pertaining to what you might see in an autism spectrum disorder, is there's a period of time in development when idiosyncratic phrases are normal. So you may have a young child, for example, who has a dog named Molly. And when that child sees other dogs, she calls them Molly. And anyone in her household who knows that there's a dog named Molly knows that she really means dog when she says Molly. But someone outside the household may not make that connection. So if the child is saying Molly, 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 she really means dog, dog, dog. But someone outside of the household may have no idea what that child is talking about. And again, at a certain age, that's developmentally normal. But beyond a certain age, that sort of becomes more abnormal and maybe more suggestive of an autism spectrum disorder. Children with autism often have a need for sameness and inflexible adherence to routines or engage in ritualized patterns of verbal or nonverbal behavior. This category is where you're going to see some of the emotional dysregulation that we see going along with autism spectrum disorders, because children with autism spectrum disorders often struggle with changes, and changes can make them anxious, changes can make them irritable. And so if you hear of a child who's becoming irritable, angry, explosive, tantruming around failure to adhere to routines, then that is sort of a red flag, and you may want to sort of consider some of the other symptom criteria for autism spectrum disorder and evaluate if this child might have an autism spectrum disorder. Again, this isn't restricted to children with autism. We see this a lot in kids with ADHD as well, for example, or anxiety. But it is something that's very particular to autism spectrum disorder. So examples would be extreme distress with small changes, something that you wouldn't even think of as being distressing. Maybe you moved the furniture in the living room. Maybe you were on the way home from the grocery store and you said you were going to stop for ice cream. And then on the way to the ice cream place, you remembered you had to stop really quickly and pick up your dry cleaning. And that for the average kid might just be a little blip, some whining. Well, I thought we were getting ice cream. What are we doing here? But a child with autism spectrum disorder may really not be able to cope with that deviation from what they thought the plan was, and they may explode. Difficulties with transitions. So, we see this a lot, especially with having to transition from a preferred activity to a non-preferred activity. And again, that's typical of lots of children. But these kids may have it in an even more pronounced way. So difficulty transitioning to school, difficulty transitioning from different classes within school, difficulty transitioning back home, difficulty transitioning to grandparents' house, et cetera, et cetera. These are kids who are really going to struggle if their teacher goes out on maternity leave and somebody new comes into the classroom, or if their aide gets a new job and they have a new aide in the classroom, or things like that. Rigid thinking patterns, sometimes these sorts of things are internal and they're not necessarily something that you're even aware of, but a child with an autism spectrum disorder may have an idea that something is going to go a certain way or something should be done a certain way, and that's their expectation, and they sort of can't deviate from that idea. For example, if a child reads about something online or sees something online. For example, I had a patient in my office the other day who had seen something online about ADHD and came in very convinced that she had an ADHD diagnosis and was really not willing to hear that maybe there was something else going on. That the amount of rigidity around the ADHD diagnosis and the amount of frustration that that patient had when I shared that I wasn't really sure that ADHD was an appropriate diagnosis, the patient became very distressed, got very upset, was angry, crying. That sort of rigid thinking is something that you might see in an autism spectrum disorder. Now, I'm not saying that that patient had an autism spectrum disorder. I'm just sort of giving you an example of what a rigid thinking pattern might look like, and the amount of distress that results from things not going the way the child had planned is way out of proportion for what you would expect in that situation. And then a need to follow the same routine each day. It may involve wanting to eat only a certain meals, only being willing to wear certain clothing, getting really distressed if the routine is disrupted. So for example, school vacation weeks can be really hard for kids with autism spectrum disorder, summer breaks, transitioning to summer break, transitioning back to the classroom at the end of the summer. Those types of things can be very difficult. Symptom criteria 3 is highly restricted fixated interests that are abnormal in intensity and focus. This can include strong attachment or preoccupation with unusual objects. So sometimes people with autism spectrum disorders get attached to objects, sort of like a lovey kind of a thing. You know, a lot of kids will have their stuffed toy or their blankie that they become very attached to. And sometimes children with autism have sort of an abnormal kind of lovey object that they carry around with them. It might be like a household object that you wouldn't necessarily expect them to attach to. Sometimes they become preoccupied with things that don't usually hold a child's interest. And then excessively circumscribed or perseverative interests. So they may love dinosaurs, but and that may be normal, or they sort of may love dinosaurs and they may only love dinosaurs and they may know everything about dinosaurs, you know, all of their scientific names and all of the facts about them, and they can recite a dinosaur encyclopedia. And so looking at the degree of knowledge the child has about certain things and how much they talk about them, and sort of, do they have other interests? You know, those sorts of questions are things you can ask yourself when trying to determine if the interest is sort of normal or excessive. For example, I had a patient who was very interested in designer sneakers. And would spend hours looking them up on the internet and talking to his parents about them. And his parents would tell him, you know, got to the point where they would say, we're really not interested in hearing about designer sneakers anymore. And he just kept talking on and on about them. And the parents were starting to get actually fairly frustrated that they couldn't get him off of this topic. So that would be an example, again, of an excessively perseverative interest. And then the final symptom category here is hyper or hyporeactivity to sensory input or unusual interests in sensory aspects of the environment. So the typical things that you hear in this category are often related to clothing. So clothing having to fit a certain way, only being willing to wear certain types of clothing, certain types of socks, certain types of shoes, not wanting to wear jeans, only wanting to wear sweatpants. You know, those are sort of typical examples. Also often related to food textures, not wanting to eat certain textures of food. But other examples are indifference to pain or temperature, having really excessive adverse response to specific sounds or textures. I'm sure people have heard of misophonia, but for those of you that haven't, it could be a really extreme response to certain sounds, often the sound of someone chewing, to the point that someone can become very irritable, sometimes yell, leave the room. That can fall within autism spectrum disorder. Excessive smelling or touching of objects, or visual fascination with lights or movement. They may love to stare at a fan, for example. So that's sort of a summary of the things I would think about when diagnosing someone with an autism spectrum disorder, and sort of thinking about what questions you might ask or what behaviors might at least trigger you to screening more thoroughly for an autism spectrum disorder. So now I'm going to move on to talk a little bit more about autism. So the CDC estimates that about 1 in 54 children have an autism spectrum disorder diagnosis, but autism is 4 times more common in boys than girls. So the estimate currently is actually 1 in 34 boys have autism spectrum disorders, and 1 in 144 girls have an autism spectrum disorder. Most children are diagnosed after age 4, as I had previously mentioned, but autism can reliably be diagnosed as early as age 2. 31% of children with autism have intellectual disability and 25% have a borderline IQ. But that means that almost half have an average to above average IQ. So it's really not a fair or reasonable assumption to assume that everyone with autism has intellectual disability. A lot of them, really, a lot of patients with autism really do just fine in school. Autism is reported in all racial, ethnic, and socioeconomic groups, however, is less likely to be identified in minority groups. So again, it exists in minority groups, but our ability to identify it and diagnose it in minority groups is thought to be not great. When you have a child with a known autism spectrum disorder, it's important to be aware of some points. In terms of medical history, children with autism are more likely to have epilepsy. About 20% of children with autism do have comorbid epilepsy or seizure disorder. They're also more likely to have sleep issues and GI issues, including stomach upset and constipation. Patients with autism are also more likely to be overweight or obese. When children have an autism spectrum disorder, it's important to consider whether an evaluation is needed for learning issues and to be conscientious of also doing standard screening for vision and hearing impairments. Autism may present similarly to or comorbid with a number of other medical disorders, which is important to keep on your differential, as these children may need referrals to genetics, and also with fetal alcohol syndrome, a good history for the pregnancy, delivery, and development can also be pertinent. And notably, any regression in previously met milestones is important and warrants a medical workup, even if an autism diagnosis is present. Plenty of children who have autism diagnoses don't suffer from any behavioral or developmental regression. And so it's always important to make sure something else isn't going on and to not just sort of mark this up to the autism. When we think about children with autism spectrum disorders, sometimes the referrals that we get in psychiatry, a patient is being referred for a question of another psychiatric diagnosis, and what comes out of the psychiatric diagnosis is actually an autism spectrum disorder. And so I wanted to just bring up some common areas where there's overlap with autism and other psychiatric disorders to give people an idea of how autism can be distinguished from other psychiatric disorders at various points. So sometimes children present with social withdrawal or a lack of social motivation. And if that is something that is new, then that is something that you wouldn't necessarily consider that representative of an autism spectrum disorder. If that's something that's long-standing, the child has always sort of lacked social motivation or interest in peers, that may be more representative of an autism spectrum disorder. But a very social child who's previously been very well related with peers and suddenly has a marked social withdrawal, that may be more suggestive of depression or possibly psychosis. And any children who have inappropriate social behaviors, but also a history of abuse or neglect, instead of jumping right to autism spectrum disorder, you may want to consider reactive attachment disorder. Another thing that often comes up is that children will be referred to us for an evaluation for OCD because they are engaging in some of the repetitive behaviors that we discussed before, where they have to engage in ritualistic behavior, or they might do certain things over and over again, and people will call these things rituals and compulsions. But what they really are repetitive thoughts or behaviors that are attributable to autism spectrum disorder. And one way to distinguish between those two things is to consider that in autism spectrum disorder, usually these actions, rituals, or acts are not distressing to the patient. They like engaging in these repetitive behaviors or rituals. It's soothing to them. Whereas in OCD, usually the compulsions or repetitive behaviors are distressing. So in OCD, a child is having unwanted obsessive thoughts that they do not like the nature of, and they feel that something bad is going to happen if they don't engage in this certain compulsions or repetitive rituals that they're engaging in. And so they're distressed by what's going on. Children with autism spectrum disorder are not usually distressed. They're usually enjoy engaging in the ritualistic behavior and are soothed by the repetitive actions. And then emotional dysregulation is something that we see a lot in psychiatry and goes along with a lot of different psychiatric disorders. Children with ADHD can be emotionally dysregulated. Mood disorders obviously comes with emotional dysregulation. And even anxiety can present with a lot of irritability or emotional dysregulation in situations that make the child anxious. So if a child is becoming emotionally dysregulated because things aren't going as expected or as they wanted them to or according to plan, that could be a lot of different, that could be any number of things, including a number of different psychiatric disorders. And it could be, not even representative of any psychiatric disorder. However, if a child has persistent issues with mood, that's something that's going to be more suggestive of a mood disorder. And I had previously discussed when we were going over the diagnostic criteria, other situations in which children with autism are more likely to become dysregulated. So autism is has very high comorbidity rates with ADHD, learning disabilities, anxiety, and depression. Also of note, children with autism may experience symptoms related to other psychiatric conditions without actually meeting the criteria for these disorders, but sometimes treatment can still be helpful. Additional concerns that may arise in autism spectrum disorder include irritability, aggression, and self-harm, which also have fairly high rates in autism. I believe I saw one website noted that up to 30% of children with autism may display signs of self-harm. When you're treating someone with an autism spectrum disorder, it's really important to make sure that that child is plugged into all the appropriate services. I know that it's really hard sometimes to figure out how to get these kids to access all these services. I mean, unfortunately, there's just a lack of resources available, I think, across the country. But these are some services that can be really helpful and important in treating autism spectrum disorder, and making sure the appropriate services are in place is absolutely necessary before thinking about medications, or at least along with initiating any medications. And now we're going to get to the
Dr. Vodrae? Yeah,
Yep.
Just a quick question from Dr. Jonathan Schwab from Northampton Area Pediatrics. And I know you have to get into the medications, but the question is about the pediatrician's role in the diagnosis of autism spectrum disorders. He was asking about whether or not pediatricians can make the diagnosis themselves. Is an ADOS or other standardized instrument required? I think a lot of it has to do with not sort of whether or not a person, any person can make the diagnosis. It's really a question of whether it's accepted, for services. But I wonder if you could speak to that.
Yeah, definitely. So I think that there's no reason that a pediatrician or any physician, frankly, can't make a diagnosis of an autism spectrum disorder. It's really just a matter of looking at the diagnostic criteria and assessing of whether or not you think the patient fits those criteria. So yeah, absolutely. If a pediatrician felt comfortable looking at those criteria and really felt that the child met the criteria, then absolutely they could make the diagnosis. If someone just isn't comfortable making the diagnosis, then it's certainly appropriate to refer to child psychiatry, or developmental behavioral pediatricians are also often comfortable making the autism diagnosis. An ADOS is certainly not required to make an autism diagnosis. In psychiatry, we make the diagnosis just based on whether or not the patient meets the criteria. However, at times when there's a lot of question about whether or not the child does meet the criteria, testing like an ADOS may be helpful. As you can imagine, if you're not someone who routinely works with children who have autism, it can be a lot harder to sort of know if the child meets the criteria or not. And so sometimes having the ADOS can be helpful. A lot of these children will also get sent for neuropsychological testing that doesn't always include an ADOS, but sometimes a neuropsychologist will be comfortable making the diagnosis on neuropsych testing, with the caveat that not all neuropsychologists are comfortable making the autism diagnosis, and also the ADOS, neuropsych testing. I mean, nothing is perfect when we're making the diagnosis. Unfortunately, there's even our gold standard of an ADOS doesn't catch autism 100% of the time. And so even if you have a child who maybe had neuropsych testing that said that they didn't think there was an autism spectrum disorder, or they had an ADOS that came back as negative, but you really feel the patient does meet the clinical criteria, you can override that and make the diagnosis. I think that to the point that Dr. Sarve was making, sometimes you need the diagnosis documented in a certain way to obtain services. So for example, I saw a patient once who needed a autism diagnosis documented using certain scales in order to get services from DDS. And the patient saw me, and I was happy to document that, yes, he did meet criteria for an autism spectrum disorder, but that wasn't satisfactory for DDS. They wanted certain scales to have been completed, and I didn't have access to those scales, and also wasn't someone trained in using those scales. So unfortunately, I wasn't able to provide that documentation. So it is variable depending upon why, who needs the diagnosis. Are you sort of making it for yourself and for the chart and for the patient and for the school? Then yeah, absolutely, you know, a pediatrician having confirmed that the diagnostic criteria is met is adequate. But if you're looking to get other certain services, you may find that that certain boxes have to be checked, unfortunately. So just jumping into the medication management piece. Medications are used to target symptoms causing functional impairment in autism. There are no medications currently available to treat social impairment in autism spectrum disorders. So again, there are no medications that treat social impairment in autism spectrum disorders. There are medications that are experimental. Oxytocin is being looked into, Namenda is being looked into, but as of right now, there are no medications to treat the social impairment. So what we're really looking at when we are trying to use psychiatric medications to manage autism spectrum disorder is symptom management. It's not, we're not treating autism. We cannot cure autism. We're just sort of managing the symptoms that go with the disorder. So first of all, the first thing you want to do is screen for other psychiatric disorders that may be comorbid with autism and treat those disorders. So if a child has autism and ADHD, treat the ADHD in the same way that you would treat ADHD in any other kid. And similarly, if the child has anxiety or depression, treat the anxiety or depression in the same way you would with another kid, with the caveat that medications, especially in autism spectrum disorder, you always want to start at the lowest possible dose, sometimes half of the lowest possible dose, and increase very slowly, because these kids may be more likely to have side effects on medications than a neurotypical child. And so you always want to start very low and increase very slowly. But do, by all means, treat any comorbid psychiatric disorders that go along with the autism spectrum disorder. However, you may have situations where a child has autism and they don't meet criteria for ADHD, but they do have impulsivity or hyperactivity. And then the question comes up, do we treat that if they don't have ADHD? And the answer is, if those symptoms are interfering with the child's functioning, then yes, go ahead and treat. So for impulsivity and hyperactivity, we still think about starting stimulant medications or alpha agonists, even if they don't formally meet the criteria for ADHD. For symptoms of anxiety or repetitive behaviors, there's no evidence for specific medications to treat these symptoms. So this is more done on a case-by-case basis. Some people certainly do use SSRIs to treat anxiety. Again, there's not clear evidence that they're helpful, but on a case-by-case basis, sometimes children and parents do find the SSRIs to be helpful for anxiety. The repetitive behaviors are much harder to treat and really, at least in my experience, don't tend to respond to medications. And really sort of the needs of that arena are probably best met with an occupational therapy referral. For sleep disturbance, of course, the first intervention is sleep hygiene. But if that does not seem to help, you can consider a low dose of melatonin or a very low dose of clonidine. And as noted at the bottom, these medications are not FDA approved. And then treatment of irritability and aggression in autism spectrum disorder. So the first thing you want to do is rule out any medical conditions that may be contributing, particularly if the symptoms are new or have sudden onset, and particularly if you have a child who is nonverbal. But in all children with autism spectrum disorder, please evaluate, make sure they don't have an ear infection, make sure they're not constipated, make sure they don't have a UTI, because any sort of new perturbation can certainly lead to increased irritability and aggression. And sometimes just treating that medical issue can help alleviate some of the irritability. Again, make sure that the patient is adequately treated if they have any comorbid psychiatric conditions, and then try to institute behavioral interventions. So maximizing services and supports as much as possible, both at home and at school. If someone has mild to moderate irritability, you can start with an alpha agonist, so clonidine or guanfacine used at a low dose and then titrated up if it's able to be tolerated is a good place to start. However, severe irritability or any risk of harming a child at risk of harming themselves or others can also be treated with an atypical antipsychotic. Atypical antipsychotics are approved for the treatment of severe irritability, aggression, and self-injurious behaviors in autism spectrum disorders. Risperidone and aripiprazole specifically are approved for this indication. It's important when starting an atypical antipsychotic to obtain baseline labs before starting them. As you may be aware, the atypical antipsychotics increase risk of metabolic syndrome, weight gain, type 2 diabetes, hypercholesterolemia, and can also cause perturbations in liver functioning tests. So you want to get baseline labs before you start the medication and then follow up on those labs regularly about every 6 months while the patient is on the medication. And then also if there's any family history of cardiac abnormalities, you may want to consider checking an EKG because these medications can prolong the QT interval. So these are the dosing guidelines for the atypical antipsychotics. Again, all the dosing information is available on the guidelines that will be published on our website. If the medication causes sedation, which can be another common side effect of the atypicals, consider nighttime dosing, or you can split the dosing so that they take it twice a day. If there's any worsening agitation or sedation, you can also consult Mcpap and we can sort of walk you through next steps. Height, weight, BMI, and vital signs should be obtained at regular intervals. There's no concrete recommendation here. Whenever you're seeing them in the office, it's good to obtain this information. And then labs should be repeated as clinically indicated approximately every 6 months. Patients with taking atypical antipsychotics are at increased risk for tardive dyskinesia, and so should be monitored using the abnormal involuntary movement scale, which is something you can just access if you Google it. It's a document that takes you through different tasks that you ask the patient to do, and then as they're doing the task, you observe for any abnormal movements. If there is any cardiac concerns, make sure to follow up the EKG once the patient is on the medication. And then if the patient starts to gain weight on the atypical antipsychotic, or they develop abnormal lab values, their cholesterol or hemoglobin A1C becomes concerning, you can try switching them to a more weight neutral agent. So aripiprazole is more weight neutral than the risperidone, or sometimes in psychiatry, we'll add metformin as an adjunct to the atypical antipsychotics to try to curb some of the weight gain and the metabolic perturbations that can go with those medications. So I think we have time for a few questions or comments if anyone had any.
Well, there's one that came in from James Bath, and he was asking about your thoughts as far as the circumstances when guanfacine would be kind of a better first line choice for treating comorbid ADHD versus stimulant medication. And I think that I'd be interested in hearing your thoughts about this in relation to hyperactivity, impulsivity in general. But James Bath was asking specifically about comorbid ADHD.
Mm-hmm. Yeah, absolutely. So the stimulants medications are the first line treatment for ADHD. And when a child has never been tried on anything, my instinct is almost always to try the stimulants first, because I do get the best results with the stimulant medications when I'm treating ADHD. However, I also find that children with autism spectrum disorders seem to just be more likely to get activated on certain medications, including SSRIs and stimulants. So some of them tolerate the stimulants just fine and do very well, and some of them can become sort of activated or more aggressive on the stimulant medications. So if I have a child who's maybe already aggressive, that may be a situation where I might be more inclined to start with an alpha agonist, just because I don't want to exacerbate that aggression. Other than that, usually I would start with a stimulant. I would start with a short acting stimulant at a very low dose. So for example, maybe Ritalin 2.5 milligrams, and just counsel the parents about the potential side effects of the medication and have them try it, because short acting Ritalin is going to be out of someone's system in 4 to 6 hours. So if it's a disaster, it's a short-lived one, hopefully. And most parents, if they know what they're potentially getting into, that the child might become activated, they might become irritable, they might become anxious, a lot of parents will still be willing to give it a try. And just knowing that the medication will be out of their system in a number of hours. If the parents really say, I don't want to do that, I'm not on board with that, I'm not comfortable with that, then we go to the alpha agonists. And then the other thing to think about is that the alpha agonists can be sedating. And so in some situations, if you have a child who's really hyperactive or impulsive, that sedating nature of the alpha agonists can be really nice. Or if you have a kid with sleep problems, giving them some clonidine at bedtime to help them sleep works well. Maybe you want to give them a lower dose of clonidine in the morning. Those might be other situations where I would start with an alpha agonist. I would say I'm probably more inclined to start with an alpha agonist in younger children as well, because they tend to not need the focus aspects of the medication. So the alpha agonists are really helpful for the impulsivity and hyperactivity, but less so for focus. And in a younger child who's in school and just sort of needs to sit for circle time or like not be bouncing off the walls at home, an alpha agonist could really be adequate for that. In an older child who maybe needs to pay attention in school because they have to learn something, a stimulant is going to be more helpful for that. So in a younger child, again, an alpha agonist may be adequate. But when we're talking sort of the more older children, I usually, really want to try to give a stimulant a good shot.
Great. So we have two other questions. I'll read the first one, or I'll sort of kind of give you a sort of an abstract of it. So the first question is about older adolescents and young adult patients with ASD or other developmental disabilities who are having difficulties kind of with their, just in the household in terms of the relationship with parents. And so this particular person was interested in your thoughts about how to integrate family therapy in these kinds of situations, and also whether or not there's kind of an age limit, for which you wouldn't provide family therapy or offer family therapy. So can you speak to that, Carrie?
Yeah, I mean, there's no age limit for which I wouldn't offer family therapy. I mean, first of all, any family could benefit from family therapy. Probably even high functioning families with no psychiatric diagnoses could benefit from family therapy. So I think at any age, family therapy has the potential to be helpful if everyone's willing to participate. When I have, in any situation, and not specific to autism spectrum disorder, I think a lot of kids don't want to participate in family therapy. A lot of times there's a worry that they are, that the therapist is going to side with the parents, that they're being labeled as the problem. Sometimes there's just no motivation on the child's from the child's point of view to improve the relationship with the family. So the way that I always sort of frame it to anyone is that we use family therapy to make sure everyone's being heard and see how we can change behavior for everyone in the family so the family gets along better. So I sort of reiterate to the child, this isn't about you or fixing you or changing you in any way. This is about figuring out how everyone in the family can change their behavior so people can get along better. So your mom or your dad or your sister, they all need to change the way that they interact with you in the same way that maybe you need to change the way that you interact with them so that the family gets along better. And sometimes when you really sort of stress that this isn't about your patient, being asked to do things, they're more willing to go along with it. And sometimes it's a matter of, having the parents go to family therapy and bringing the kid along a couple of times. And maybe they don't always go to family therapy. Maybe just the parents go sometimes, but sometimes even that can be helpful in figuring out, techniques with parenting and how to interact with people at home.
So last, I think we have time for a couple of quick hits for two questions. So one is just about any thoughts as far as handoffs to adult providers, I guess also in relation to some of these young adult transitional age youth with developmental disabilities. Do you have any kind of ideas about that? I know that's a challenge, for many of us.
Yeah, I mean, it's definitely a challenge. Off the top of my head, I don't know because I see both children and adults, so I don't hand my patients off. I would imagine at some point getting, DDFs involved is very important. The other thing to think about, for those of you that see children above the age of 18, transitional age youth, is that if you're prescribing an atypical antipsychotic to someone over the age of 18, if it's someone who guardianship paperwork is going to be completed for, they need a special Rogers guardianship for those atypical antipsychotics as well. Sorry, that wasn't to the question, but
That's okay. Yeah, yeah. No, I think it's sort of there's two answers in a way, like because there's a need for the handoff for the pediatrician, since most pediatricians, unless you're, I guess, if you're a med peds person, or a family medicine provider, then you can take care of the patient all the way through. But it is hard to find good primary care for patients with developmental disabilities, as well as specialty care. So I think it's a challenge for everybody. But I'm afraid we don't have, any sort of specific sort of guidance for that. But I think that's something that Mcpap research and referrals coordinators can help with. So I would encourage people to call Mcpap, with that type of need, and particularly around the specialty care for patients. I guess the very last question we have time for is from Despina Lakakis, and she was wondering if we have any advice as far as how to get past the long waiting lists that exist for having ABA services and also ADOS testing. And whether there are any agencies that we know of where the waits are not so long. But what do you think about that, Carrie?
I do not know anywhere where the wait lists are not so long, unfortunately. Like I had mentioned, in situations where the formal ADOS is not maybe needed, like a diagnosis from a psychiatrist or a developmental behavioral pediatrician could suffice. Sometimes it's not this day and age, it's not that easy to get in with a psychiatrist either, I think. But sometimes you can refer to a psychiatrist or a developmental behavioral pediatrician to help at least assess for and make the diagnosis if the ADOS isn't necessary for the services that you're trying to access. But no, though, the wait for ABA is atrocious. And, for patients that I see, even just for medication management, I struggle probably just as much as the pediatricians trying to get my patients ABA services, unfortunately.
All right. Well, on that note, unfortunately, it's not a sort of a pleasant, sort of reality, but in general, I think Mcpap, research staff to kind of help find ABA services. But we can't pull a rabbit out of the hat all the time, but I think that we can help, with that, and try to see where the weight is the lowest, and it varies a lot by region. But thank you so much, Dr. Vaudreuil. That was really nice, and thanks everybody for your attendance. And we'll be back with you April 27th, I believe, is the fourth Tuesday of the month of April, for a discussion about ADHD. It's a refresh of the ADHD clinical practice guidelines. So we look forward to seeing you then. But thanks everybody for coming, and please take a moment to fill out the evaluation. It's really easy and quick. So thank you in advance for doing that. And thank you, Dr. Vaudreuil.
Thanks, everyone.